Hello and good evening, everyone. Welcome to my IVF Answers and welcome back to our webinar tonight. And it's great to be here with all of you. I hope you can hear us loud and clear. And we have another special guest, Dr. Vladimiro Silva, is with us already. So I'm glad that you were able to join us tonight. And how are you feeling? I hope you are well and are ready to discuss this topic tonight as well with us.
Hi, Caroline. Well, thanks for the invitation. It's always a pleasure to participate in your events. I'm very happy to be here to answer all the questions. And so I will do my best. This was a little bit last minute, but it's fine. It's a
It's true.
topic that I always like to discuss because this is part of our daily routine. This is the kind of questions that we get every day. So I'm very happy
True.
to give my best on this
Yes.
presentation.
Thank you so much indeed. We are always happy to have you here. Let me just mention that Dr. Vladimiro Silva is the founder, CEO, and also embryologist at Ferticentro and also Procrear. So two of the leading actually clinics in Portugal. And we've done many, many webinars with Dr. Vladimiro, and he's always great with explaining things. So I'm glad that you are here. Thank you for agreeing. This is it's true. It's a kind of a last minute thing. We had some issues, as you know, with the situation in Ukraine. Some of our doctors were not able to simply right now just simply present. We did some webinars, of course, with brilliant, amazing teams. So we are definitely supporting them. And I'm glad that you, Dr. Vladimiro Silva, was able to be here, of course. And as you know, today's topic is definitely an interesting, intriguing one for sure. And so Dr. Silva will discuss it with his presentation. So I guess we can go ahead. This is going to be recorded. And remember that after his presentation, there will be time for your questions. So you just need to put those questions in the chat section. And Dr. Silva, I'm sure, will be happy to answer them. So thanks a lot, everyone, for coming in. I know that you are from different places. I'm glad that you are here, and I'm sure it's going to be useful. And I think let's get started. Let's share your
Okay.
screen. Okay.
Okay, let's start then.
Perfect.
Well, first of all, I would like to give a word of support to our Ukrainian colleagues that couldn't participate in this webinar. It's a shame to be here in spite of them, but I will try to honor them and to do my best efforts. I know that they will overcome this unbelievable situation. We all support them. I believe it's a general thing all over the world, and
It's true.
so I'm very happy to give them my place in the future if they want if they are able to do a webinar back.
We are
So
definitely waiting for that, right?
okay,
Thank
so
you so
let's
much.
start then sharing the screen. 1 second. Uh, I'm listening to my own voice, Caroline. There is something wrong here.
Some echo, but I think in a second should be okay. We can see your presentation already, so
Okay,
all should be
okay, it's
okay.
fine. So let's
Perfect.
start. So our topic tonight is should you do PGTA if you are over 35? Okay, this is kind of, I wouldn't say the $1,000,000 question, but it's one of the questions that we hear the most in our daily routine. Instead, there are people that say that we always should do PGTA. Well, first of all, let's explain what is PGTA. PGTA is the acronym for Preimplantation Genetic Testing for Aneuploidies. And what are aneuploidies? Those are chromosomal numerical abnormalities. This means that this is a test that is used to see whether you have the right number of chromosomes on your embryos. Okay, and so we know that with age, the probability of having an abnormal embryo increases. The most known abnormality of this kind is trisomy 21, that increases with female age. And so this is why the question of doing this genetic screening after the age of 35 is kind of a recurrent topic with lots of patients asking the same questions. So the answer is actually very easy. It depends. Okay, so there is not a clear answer for this question. First of all, because every patient is different, the risks are different, and we need to assess multiple factors. The first thing is, so let's talk a little bit about IVF and genetic diseases, because IVF is in reality, one of the most used strategies to avoid genetic diseases. There are multiple strategies to prevent the transmission of these genetic diseases, and so pre-implantation genetic screening, the so-called PGTA, is just one of them. So we use IVF to prevent genetic diseases in many ways. So IVF can be used to the prevention of genetic diseases, meaning if you know that you have a certain disease, IVF can prevent the transmission of genetic diseases. That's the case of monogenic diseases. This has nothing to do with PGTA. Okay, so sometimes patients say, but what kind of disease am I preventing here? It's not, this is for diseases that you know that run in your family, that you know that you are a carrier for those diseases and so on. Another thing that we use IVF for is to screen for genetic risks. That's where PGTA is. Age-related risks, balanced translocation. So sometimes you're a carrier of a balanced abnormality that wouldn't cause any disease or any problem with you, but can cause problems while you are forming your eggs and sperm. So this is one of the risks that we need to address. And so PGTA is on point number 2, screening for genetic diseases. We can also do another type of screening that sometimes patients ask for it and make a confusion between this test and PGTA, which is the genetic carrier tests. Those are completely different things. In the genetic carrier tests, we screen the patients to know if we are, because we're all carriers for rare genetic diseases, and there are tests that we can do to ourselves to see if we have the risk of transmitting a genetic disease. If our partner is a carrier for the same very rare genetic disease, there would be a 25% chance. We will address all of these topics later, and obviously there are situations more complicated where we can try to obtain embryos that are HLA compatible, for example, to allow for a bone marrow transplantation on a sibling because we already have an affected child or a child affected with a serious disease, and those embryos can be used to create a compatible sibling. Okay, so transforming this into the tests. In the prevention point, we have PGT-M, pre-implantation genetic test for monogenic diseases, PGT-SR, pre-implantation genetic testing for structural rearrangements. In the screening, the PGTA, which is the topic of this webinar, PGT-SR, the same, because it's used the same method, so it's kind of a different way of classifying. The carrier screening tests are tests that are done on your blood, on the patient's blood, so not on the embryos, and we can screen for packs up 300, 400, 2,200 diseases. There are multiple offers in the market, and then we have the pre-implantation genetic testing for HLA. Starting with pre-implantation genetic test for monogenic diseases. This has nothing to do with age. Okay, so if you are a carrier of a disease such as Huntington disease, neurofibromatosis, cystic fibrosis, etc., this means that you were born like this, and the risk of transmitting that disease to your child will always be 50%. And obviously, if the disease is an autosomal recessive, you need your partner to also transmit the same gene for the same disease. If the disease is autosomal dominant, the mere fact that one of you transmit the gene can already cause the disease. So the incidence is 50% for autosomal dominant diseases and 25% for recessive diseases. This is intended by patients who are known to carry these serious genetic diseases that run in their families and so on. And these tests have to be custom designed for every patient. They are quite complex to establish. Screening for genetic diseases, for genetic risks that are age-related. The topic of this webinar, the pre-implantation genetic testing for aneuploidies. it's what we will essentially be talking about. And the big question is it worth to do after the age of 35? Is it worth to do at any age or maybe later? Well, let's look at the numbers. First of all, let's remember what this is. This is what was formerly known as pre-implantation genetic screening, PGS. So PGT-A is a genetic test that is performed on embryos to screen for numerical chromosomal abnormalities, meaning aneuploidies, embryos that have an extra or a missing chromosome. Those embryos that have these extra or missing chromosomes often fail to implant. So the most likely scenario when you transfer one of these embryos into the uterus is that you have a negative pregnancy result. But they can also lead to a miscarriage, or in some situations, implantation can be successful. And these embryos sometimes are even compatible with life, which would lead to the birth of a child with a genetic condition. The most well-known of these conditions is trisomy 21, but there are others, trisomy 13, trisomy 18. So there are multiple diseases that can happen. Embryos found to be chromosomally normal are referred to as euploid. Okay, that's what we want when we do these tests, and are the most likely to lead to a successful pregnancy. At Ferticentro, and I believe in all main clinics worldwide, we do pre-implantation genetic testing with next generation sequencing, NGS, that allows us to analyze all 24 chromosomes, because we know that we humans have 23 pairs of chromosomes. So we have a pair of chromosome 1, 2, 3, 4, 5 until chromosome 23 and 22. And so the 23rd pair of chromosomes are the sexual chromosomes. If you are a man, you have an X and a Y chromosome. If you are a female, you have two X chromosomes. Okay, this is why we say that we have 24 different types of chromosomes. And so we do the next generation sequencing to analyze the quantity of these chromosomes. Okay, it is so chromosomal abnormalities are, in these cases, are detected prior to embryo transfer, and so this will allow patients to make informed decisions about their treatment. It is very important. This is a message that I always tell patients. PGTA will not make your embryos better. It will not give you a better chance of pregnancy. It will just give you information on the. It will give. This is all about information. So it gives us information on our capacity to select the best embryo. So we can identify the embryos that are most likely to originate a pregnancy, but it will not transform a bad embryo into a good one. It is very important. So this is about information. This is about making decisions. For example, if we always have embryos with the wrong number of chromosomes, this could actually mean that we might consider egg donation instead, or sperm donation if it comes from the male side. So I'm really sorry. You are probably listening to my cats, but I'm doing this from home. So, like I was saying, it will not make your embryos better. It will just give you more information about your embryos, and it will help you making a better decision, or at least a more informed decision. Naturally, because we are able to identify the embryos that are most likely to implant, this will reduce the number of cycles needed to obtain a pregnancy. But once again, if the embryo is not viable, it is not the PGTA that will transform it into a viable embryo. So what about the question that is the topic of this webinar? Should we do this above the age of 35? Well, we have these statistics. These were published by iGenomics, by the iGenomics group. iGenomics is one of the genetics lab, one of the most well-known genetics lab in the world, and they do a lot of a lot of research on this topic. We work with them for multiple tests, including PGT-A, and so they have found, based on their records, that the incidence of aneuploid blastocysts, sorry, these are my cats, the incidence of aneuploid blastocysts increases with maternal age. So we know we can start at, when we start at the age of 35, we see that 36 to 40% of the embryos are aneuploid, meaning they have a wrong number of chromosomes, and that number starts to rise, and it rises very steeply, especially after the age of 38. By the age of 38, 39, we already have 61% of the embryos being carriers of genetic abnormalities, and at the age of 43 or 44, we have 76% of the embryos carrying abnormalities. So so this is probably our answer. Okay, in Portugal, the IVF authorities have established that we can do that. There is an indication for PGTA after the age of 39, which is more or less here, when we are at around 61%. This is, I think, it's actually a good threshold, because that's when you have the majority of the embryos being carriers for chromosomal abnormalities. Obviously, there are people saying, but why not to test it at any age? If the chance is different than zero, why shouldn't we do it? Well, it is obviously arguable that this could be an acceptable approach, because naturally, the more we know about our embryos, the better. So personally, I'm very in favor of PGTA. So I would, if I could legally, and obviously financially, if I could, I would test all of the embryos, because as an embryologist, we always prefer to transfer embryos that we know that are tested as a clinic. We need to know where to focus when we have a negative result after transferring a tested embryo. It has a completely different meaning than when we have a negative result after transferring a non-tested embryo. But obviously, we have to balance that need for information with the real benefit for the patient. And we know that if we look into statistics of PGTA, we will see that, roughly speaking, 70% of the cycles in all studies published, when we transfer embryos that are tested, we get 70% of pregnancy rates, which is more or less the same that we get below the age of 35. So it's not really much of a difference. So why do an invasive procedure to the embryos that can lead to a 2% embryo loss, that will lead to embryo vitrification? Embryo vitrification itself can have another 2 or 3% embryo loss. So we would also be losing maybe healthy embryos, because we would be doing these extra procedures. We would also be adding extra costs to the process. Then there is also the question about mosaic embryos, which is a completely different topic. So it's not a very easy decision. So I think the Portuguese approach is acceptable. There are indications to where I mean, the age of 39, I think it's a completely understandable threshold. maybe we could lower it a little bit to 38 or 37. Or if you have already 3 negative results, then I would say it's really needed PGTA. If you had a previous miscarriage, if you have a previous pregnancy with an abnormal, with an aneuploidy, for example, with an embryo that was a baby that was diagnosed with a genetic disease. So if we can isolate those cases, then the rest of the patients is very is very unlikely to have problems. So maybe the 39-year-old threshold will be more appropriate than the 35, because at the age of 35 is kind of early. We have 37 to 40% of probability of having an abnormal embryo. But once again, as an embryologist, if I could test all the embryos, it would be better. But when we weigh the pros and the cons and the benefits and the financial costs for the patients, then we have to understand that the 60% that we get at, roughly speaking, at the age of 39 is probably a more sensible approach. This is another statistics from iGenomics where we can compare implantation rates in a group of patients that did PGTA and in a group of patients that just transfer the embryos without testing them. In the gray bars, those on the left-hand side, you can see that the probability of pregnancy is relatively stable through all health groups. There is a slight drop in pregnancy rates, but not a very significant one. While when we don't use PGTA, the drop is more clear and the differences are bigger. Why does it happen? Once again, PGTA doesn't improve the quality of the embryos, but it does help us to select the best embryos, the embryos with the best prognosis. And so the difference between these two groups is that while here we are still transferring embryos that were not tested, and so we are transferring a lot of embryos that are aneuploid, having the wrong number of chromosomes. Here on the gray bars, we are only transferring embryos that have been tested. This is why the pregnancy rates, so it's a selected sample of embryos. Okay, so PGTA helps us to remove the difference between these two bars. This is what PGTA helps us to do, to focus on the embryos that have a real potential to implant and avoid and lower the number of embryo transfers needed to obtain a pregnancy. When we look at the statistics at the delivery rates, we see the same thing. Okay, so obviously you are more likely to have a miscarriage, and we have the miscarriage rates on the right-hand side if you are transferring an embryo with the wrong number of chromosomes. This is completely clear, and so obviously with the increase in the miscarriage rate, there is a decrease in the delivery rate, obviously, because if you are pregnant and you're not delivering, that's because you had a miscarriage. Okay, then the PGT-SR. Well, this is a kind of a special and very specific type of PGT-A for patients that have that are known to carry karyotype abnormalities. So the karyotype is kind of a formula of your genetic constitution, and sometimes people can be a carrier either inherited or spontaneously of those chromosomal rearrangements. It is estimated that 1 in every 500 persons can carry a balanced reciprocal translocation. Patients are unaware of this. They don't have the slightest idea. They only discover it when they are trying to get a pregnancy and they are not getting pregnant and they don't know why. Then we do a karyotype and we identify that, but patients live otherwise normal, healthy lives. Knowing that carrier status is very important. But again, the only thing we can do is to test the embryos. We cannot modify. So if all the embryos carry abnormalities, it's not possible to do anything. There are multiple types of balanced rearrangements like duplications, deletions, inversions, translocations. So this is a very specific type of situation. One thing that I'm talking about here, because a lot of patients ask for this, and then there is kind of a confusion between PGT-A, in which we are screening for abnormalities in the number of embryos, with the genetic carrier screening, where we are screening for rare recessive diseases. Well, like I was saying before, we're all carriers for something, okay? I never did any of those tests, but I'm sure I will be a carrier for 5 or 6 rare mutations. And if I have a baby with someone who is a carrier of the same mutation, I have a 25% chance of having an affected child. Okay, this is an example on how these diseases are transmitted. If the father and the mother are both carriers, okay, they can either pass the orange part, and then we have an healthy not carrier. They can pass one of the orange parts and one of the gray parts, and we have healthy carriers. But if they do pass the wrong part, the gray part, we have an affected child, and that can happen in 25% of the cases. Then there are multiple tests in the market that can screen for these diseases. For example, we work with iGenomics on this. They have 2 tests, one where we screen for 570 diseases and the other one with more than 2,200 diseases. The chance that we find a carrier are 55% or 67% in the largest of the tests. But again, this is completely different. This is not PGTA. This is something that is done on the blood of the patients or the sperm donors or the egg donors. This is something that we do in order to understand whether people are carriers of recessive genetic diseases. Has nothing to do with and you apply this with the number of chromosomes in an embryo. Okay, so here we have a better image of that. The most common monogenic disorders detected in these tests are cystic fibrosis, spinal muscular atrophy, sickle cell anemia, Fragile X syndrome, beta thalassemia. I mean, there are lots of diseases. Probably you've never heard of any of those, which is a good sign. The question here is whether this is a Pandora's box or not, because once you know that you're a carrier for something, you will always have to do this test if you try again. And then if you have a brother or a sister who is also trying to have babies, you probably should share that information with them, because there is a very good chance that they're also carriers. But maybe then you don't want to share with them the fact that you are doing IVF and being tested, or maybe that you are doing egg donation and you are being tested to see if you are compatible with an egg donor. Okay, so this causes a lot of ethical issues, a lot of ethical dilemmas, and especially it's kind of a Pandora's box. Sometimes it's preferable not to know, not to be involved in all of this kind of madness where we need to do a lot of tests. It's completely indisputable that gives you more safety. It's more secure. It's the more you know, the better. It lowers significantly the risks, but you have to be very well informed and very well prepared to cope with having this information. Okay, another situation where we do genetic testings is to find HLA compatible embryos. I will not spend a lot of time talking about this. This is to sometimes when we do for certain diseases, we need to find a compatible stem cell donor, and the only solution is to have a genetically compatible sibling. This is something that requires the approval from the national IVF authorities. It's a very complicated, those are very complicated cases. We have done those with success in the past, but it's always very complicated and kind of stressful, and sometimes we need a lot of embryos to be lucky enough to find a compatible one. Okay, but at the end of the day, what we all want is an healthy child. And so this is what we're here for. This is an old picture of our team. Now we are kind of twice as many people as there are in this photo, which is good. But and so we are here. We are very happy to help you and assist you in your projects. So if you have any questions, please don't hesitate to visit our website, call or write us, and I'm very happy to help you on this. Okay, so back to you, Caroline. And as always, it was a pleasure to be here.
Brilliant, as always. Thank you so much indeed, and I do believe that it was very, very useful. And this is a topic that you've discussed before, but I think it's still a topic that we should discuss even more because it's not an easy thing. And as you can see, there are plenty of questions right here as well. So thank you so much, everyone, for your questions. Some of those are always detailed, so we appreciate also that you are sharing, and we hope that we'll be able to help you. Of course, Dr. Silva is right here to help you out with those, right, Dr. Silva? So
Yes, I am. So please go ahead. I'm available.
let's go ahead with the very first question, of course. After 35, we have less embryo obtained, and if we do PGTA, maybe just have one biopsied embryo to transfer. What if it is mosaic? Professor Gleicher has proven a lot of diagnostic mistakes in that matter. What do you think? Thank you.
Well, this is one of our main concerns, okay, because there are many points that Jorge Ramirez is focusing. So, first of all, it is true that the older the patient gets, the lower is the number of eggs, and hence the lower is the number of embryos. Okay, but at the same time, this is when we are more likely to find abnormal embryos. So we really need to do this in a more advanced stage because this is not about justifying the need for the procedure. I think we can even do it if we just have one embryo, because this is about having information to decide on our reproductive future. Okay, I would say that the number of embryos is not very important. It is important to be able to decide. Obviously, if we can decide without PGTA, that's preferable, but it's certainly a useful tool. Regarding the mosaicism, what is that? So all the other persons understand. In the embryo, there are multiple cell lines. There can be more than one cell line. So, and when we are doing PGTA, we are making a hole in the embryo. The embryo is like a ball, and we make a small hole and we retrieve kind of 5 or 6 cells. Those cells are then analyzed. We take those cells of the embryo from a part that's called trophoectoderm, which we find to be representative of the embryo. Many studies have reached the conclusion that they are representative. But obviously, we can never exclude the possibility of that there is another cell line inside the rest of the embryo that was not included in the biopsy that could be normal and take over the embryo that can still have an implantation potential. So there are studies that have been done with embryos that were considered to be abnormal that ended up implanting and originating normal babies because those were mosaic embryos. Those are rare. Okay, the probability of that happening is low. There are now strategies to, because when we transfer a mosaic embryo, there are a lot of concerns. One of them is, for example, if you transfer a trisomy 21 embryo based on the assumption that it could be a mosaic, that's a very high risk because trisomy 21 is compatible with life, as we all know. So if that's not the case, you can have an handicapped child. So on the other hand, if you have, for example, a trisomy 4 embryo, which is not compatible with life, then you can maybe take the risk if you don't have any other embryos, because it would either be a negative result or a miscarriage, but you will never have a child born with a trisomy 4 because that's not compatible with life. Okay, so we need to address every situation carefully because transferring an embryo carrying an abnormality that is compatible with life is a very huge risk. And so the remote possibility that it could be a mosaic doesn't justify the risk, in my opinion. On the other hand, if it is an embryo that carries an abnormality that is not compatible with life, you kind of have nothing to lose. You can risk the embryo transfer. The worst case scenario, you will get a negative result or a miscarriage. Having a miscarriage could actually cause problems in subsequent pregnancies. So this also needs to be addressed carefully. But again, if there is no alternative, if that's the only embryo available, then it's either that or nothing. So maybe it's justifiable. On the other hand, there is now, I haven't included it in the presentation, there is now a new test, a new way of doing pre-implantation genetic test that looks very promising, which is non-invasive pre-implantation genetic testing. What is that? So instead of making a hole in the embryo and retrieving 5 or 6 cells, we are analyzing the free DNA that lies in the embryo culture media. So in the media where the embryo was cultured. So that DNA is theoretically representative of the whole of the embryo. So so that makes so in principle it should be a better representation of the different cell lines that might be included in the embryo, that might be present in the embryo. So the problem with non-invasive PGTA is that we're still in the early days of non-invasive PGTA, so it's relatively soon to generalize its utilization, and the concordance between the trophoectoderm and the free DNA in the culture media is only around 85, maybe 90%. So it's a very, very promising technique. We are actually implementing it in our labs, but it's still not the same as doing let's say a classical PGTA. Okay, but that's a way of addressing this mosaicism issue that Jorge is mentioning. Okay.
Brilliant. Thank you so much
Okay.
indeed. And I would like to just say that actually we will have a webinar in the nearest future. I don't remember exactly when, on that non-invasive PGTA, and I think that's going to be actually one of your doctors at Ferticentro, Dr. Paula. So it's going to be soon. Look out for it. So you will see it. Just go to our upcoming events, and I think that it's already there. Actually, it will be in April. I will double check. Thanks so much, Jorge, for your question as well. And let's have a look. There's another one coming in right here. So my first 3 IVFs and ICSI cycles were with juvenile sperm and ultimately no embryos to freeze and no live birth. Now have good sperm from TZ, but first IVF cycle transferred 2 embryos, 2 births, 1 healthy and 1 other had chromosome abnormality. Lived 10 months, also 4 frozen embryos, 3 transfers separately, and all failed. I have 1 frozen embryo. Now in new IVF cycle, egg collection will be tomorrow, and I am 35 given our history. Should I PGTA test embryos, including the frozen embryo?
Yes, okay, because so first of all, when we work with this sperm, there is always a slightly increased risk of having an embryo, a genetic abnormality, but still the vast majority of genetic abnormalities come from the egg, not from the sperm. This is statistics. Nature works like that. On the other hand, since Fran is only 35, I would say that in principle she's on the good side of statistics, or at least it shouldn't be too bad for her. I honestly don't know exactly what genetic disease was, but if it was clearly identified, then uh, definitely she will need a genetics consultation to so we can address the risk of recurrence, to see if there is if she's at an increased risk to have this same problem again, or if it was just a random event that can happen to everyone, uh, meaning just bad luck. Okay, so anyway, having still one embryo, I would definitely test it, and doing a new cycle, I would also definitely test it because they have passed by a lot, and they have done a lot of cycles. You know, this is the example that I was talking about in my presentation. 3 IVF cycles. Okay. So probably it was a de novo mutation, which which is not inherited. So it was just bad luck. Okay, but again, so they have done 3 IVF cycles. They've done a lot of embryo transfers with negative results. So there is a clear indication for preimplantation genetic testing. I would definitely do it because not only, I mean, probably that disease has nothing to do with PGTA. That would have been normal in a PGTA test. It will require a genetic consultation to see if there is any risk of having the same problem again. At first sight, I would say no. It seems like a random event, but I'm not a genetic specialist. Um, so, um, but based on these results and the bad experience that they had with so many difficulties, I would certainly advise PGTA before transferring either the old embryo or the new ones.
Brilliant. Thank you so much, Fran, for sharing. And actually, Fran has another question. Let me go straight to that one. We will go back to the previous ones. If you can clarify this. So can a previously frozen embryo be transferred alongside a fresh embryo?
Yes, we can warm the embryo, do the biopsy. We have to freeze it again, and then we can wait for the PGT result. If the embryo is normal, we can warm it again and transfer with alongside with the fresh embryo. I mean, but again, if we are doing PGTA, we're not working with fresh embryos. We are always working with frozen embryos, okay? Because PGTA requires, especially if we work with next generation sequencing, we need about 2 weeks to have the genetic results, 2 to 3 weeks, depending on where we are. So we need to obtain the embryo, do the biopsy, vitrify, freeze them, then thaw the embryo, and do the embryo transfer if the embryo is normal. And we can thaw the frozen embryo, do the biopsy at the same time with the fresh embryos that are being collected, and freeze them all again. Even for non-invasive preimplantation genetic testing, we can do that. We can warm the embryo, culture it for at least 8 hours. There would be enough free DNA in the culture medium for us to analyze it and have an opinion. So that's also one of the possibilities.
Excellent. One more from Fran, okay, as we are still talking about this. So would the double freezing on current embryo not cause any deterioration?
There is a risk associated with it. Okay, we've done that multiple times. We have a lot of babies born from embryos that were frozen twice, or in some cases 3 times. And so still the babies are born, but obviously the more we manipulate, the more we touch the embryo, the more riskier it gets. I don't have statistics for that. It will certainly lower the implantation potential of the embryo, but it's a balance between what you get from testing the embryos and what you lose from testing the embryos. And in a case such as this, I would definitely test the embryo.
Perfectly understandable, of course. Thank you so much indeed for your question, Fran. I do believe it has been helpful for you. And as I mentioned, our topic on non-invasive pregnantation genetic testing will be on the 5th of April with Dr. Paula Manso from Ferticentro. I will put a link if you wish to get, register for it. You can do it, of course, here as well. Okay, and let's get going with another question here from Christine this time. Is if the stimulation medication is too high, can this have an effect on embryos, and could this cause damage?
Well, this is a controversial question because until 5 or 6 years ago, yeah, more or less, that we all thought that a stimulation that was too high would decrease the quality of the embryos, of the eggs, and so having too many eggs would be bad and could actually lower the pregnancy rates. But more recent studies have been published in the last few years, and apparently the pregnancy likelihood continuously increases even with very high number of eggs. So in principle, so we don't know, okay, but the most recent research seems to indicate that in principle it shouldn't have an effect on embryos. Obviously, we have to balance this with the risk for the patient. We don't want the patients hyperstimulated. We need to trigger the ovulation with the agonist, with a special drug that prevents the ovarian hyperstimulation syndrome. If we do that, we cannot transfer the embryo in that cycle. We have to freeze the embryos and so on. So my advice, especially if Christine is older than 35, is for her to try to do a strong stimulation, trigger with agonist like decapeptyl, then take the embryos to day 5. If she meets the criteria, do the PGT-A, freeze the embryos, and transfer the euploid ones. I think that's probably the way to go for her.
Amazing. Thank you so much, Aden, for yet another advice. And if you can clarify, okay, so did you say PGTA has to be done only in frozen embryos? Is it minimum 3 weeks process to wait for the result before transfer can be made?
Not exactly. So PGTA can be done on fresh embryos, but then we have to freeze the embryos. Okay, so we fertilize the eggs. We take the embryos until day 5, 6, or even day 7. We do the biopsy and we freeze the embryos on that day. Then we will wait for about 3 weeks, 2 to 3 weeks, for the results from the genetics lab, and then we can schedule the transfer. In the past, people were doing PGTA, doing a biopsy on day 3 and the embryo transfer on day 5 or day 6, but that was too risky for the embryo, and we were only taking 1 or 2 cells from a day 3 embryo that has 7 or 8, that has 8 cells, roughly speaking, and so it was too aggressive for the embryos. The embryo degeneration rates were high, and it was not as informative as an NGS biopsy, not only because next generation sequencing is way more accurate, and so it gives us better information, but also because it's based on a higher number of cells, so that has been completely abandoned. So we only work with frozen cycles when we are doing pre-implantation genetic testing.
Thank you. And actually, we do have another question from the very same patient. It's a bit of a longer question with some details. Let's have a look at it. So here it is. I have had 8 donor egg transfers with 3 different donors from these 2 chemical pregnancies. The rest failed implantation. Before the age 45, I had a natural pregnancy with missed miscarriage. I am 50, my partner's 37. We have had many tests, all normal karyotype, no explained reason for failure. My partner also had fish, DNA fragmentation, meiosis test, all normal. If you were to do one more cycle of donor egg IVF, would you recommend doing PGTA, in our case, bearing in mind would only be able to do one or possibly two more transfers maximum to the age and finances. Is there any other test or HLA, other donor matching screening you would recommend?
Well, well, it's amazing. It's a lot of embryo transfers. Okay, so in Portugal, this wouldn't be possible because we can only treat patients up to the age of 49 years and 364 days. The day you turn 50, you are no longer eligible to do a treatment. In other countries, this could still be possible. Um, what I mean, I don't know anything about the quality of the embryos and the way, but with three different egg donors, eight embryo transfers, I guess it is very likely that at least some of these embryos were viable. Okay, so what I would do here is this. Maybe she should focus on the window of implantation, on the endometrial factors rather than the quality of the embryos. So in this case, I mean, you can do PGTA because obviously the problem can also come from the male partner. And she did the ERA test. ERA test is the endometrial receptivity assay, so it's to assess the window of implantation. So obviously we can try to consider the possibility of that these problems can also come from the male partner. Okay, and so in that sense, doing PGTA is, I would say, it's acceptable. I would recommend it, but still, I would think it seems more likely that the problem is on the uterine side than on the embryo side. But having so many failures, I would do the PGTA. Okay.
Again, makes perfect sense, of course. Thank you
And
so
good
much.
luck. Okay.
Definitely. Best of luck to everyone, really. Of course, we definitely want to hear some good news. That's always the case. Thank you so much for the patient for you here. All right, let's have a look. There are a few questions left. Let me just go to Christine's question. For a low-grade embryo, is there a chance for that embryo to be healthy?
I mean, there is, okay, because in fact there are studies that have shown that the way that we grade embryos is not as effective as we thought a few years ago. For example, there was this research paper from some Italian investigators. I can actually share my screen and show you this because it's a study that I always keep in my desktop to show patients because its conclusions are amazing. Can I share my screen, Caroline?
Yes, sure.
Okay.
Cannot see it
Well,
yet, but of course, go ahead.
okay. So I'm sharing my screen again. Um, so here we go. This is a study from Antonio Capalvo from Italy and their group. I'm listening to my own voice. So maybe. Okay. So they a study of 956 blastocysts. 956 blastocysts, meaning day 5 or day 6 embryos, that were tested for PGTA, for embryo abnormalities. And the amazing thing here is this graphic. You see, according to embryo morphology, to the classification, then they were assessing the probability of that embryo being normal or abnormal according to its respective classification. And you see that there is really not much of a difference. Even a poor quality embryo had a 54% chance of being normal. There is a lot of feedback here. So this is incredible and shows how how low is our capacity to identify just based on morphology alone the implantation potential of an embryo. So these days, morphology is becoming something of the past. We are more focused on morphokinetic parameters from video time lapse. Artificial intelligence, it's giving its first steps in understanding whether the embryos are viable or not, with based on factors that are invisible to the human eye, but that are possible to be detected by a computer, and then on genetics, on non-invasive implantation genetic tests and on invasive PGT-A. So, but this is really what we get, okay? Even between day 5 and day 6, there are not significant differences, and between the different rates, the different ways where we rate the embryos, there are also not no differences. So the take-home message here is this: we well, I'm still having feedback. I don't know why,
Yeah, sorry, if you are able to perhaps close one of your browsers, because I think you have two of them opened and possibly that is interfering, I think
okay,
might be the case.
okay,
Let's try.
okay, but no, just that one.
Okay, so maybe something else is interfering. Hard to say right now, but for me, I mean, we can hear you, so let's try.
Okay,
Okay.
let's keep trying. Okay,
Yep.
so I think it's better now. So like I was saying, when we are so the embryo quality, so a low grade embryo is a classification in the lab. It is kind of the old way of looking into embryos. So like I said, apparently from that study with almost 1,000 embryos, the chance for that embryo to be healthy is more or less the same as for a high-grade embryo. And in fact, what we have learned from the past, from our classification, is this. From the moment that we have a blastocyst, this is a good embryo. Okay, so forming a blastocyst is already a very important step. Uh, and then the quality of that blastocyst is more or less time sensitive, subjective. There is a variability between operators, meaning two different persons assessing the same embryo can have different opinions. And so I would say, obviously, we prefer to have high grade embryos. We always feel more comfortable. We're working in this field for 20 years, so I mean, we are very happy when we have these wonderful new embryos, good quality embryos. But um, I but still, apparently, there is not much of a difference.
Thank you for your thorough clarification and, of course, for the statistics as well. Thank you so much for that. And let's have a look. Diana has another question. So, what are the complications, if any, of having early miscarriage in future pregnancy?
I mean, if you have to do a curettage, then it's an aggression to the uterus. There could be infections. You could be triggering immune factors. So, I mean, the less we manipulate the uterus, the less we aggress the uterus, the better. Okay. Sometimes having a miscarriage can be a problem. Obviously, if the miscarriage goes away spontaneously, then in principle it shouldn't be there shouldn't be any issue. But there are situations where we get remnants from the past pregnancy. We have to do procedures to remove them. So. So if we can choose, it's way preferable not to have a miscarriage. If that's something we can avoid, we should do everything in our hands to avoid that.
Thank you for the clarification as well to this one. You have mentioned you already are doing non-PGTA, right? In non-invasive PGTA at your clinic, Ferticentro. Anywhere else? Do you know anything about that?
Well, we are about to start doing, okay? We
Okay,
are
yeah,
still validating it with our with iGenomics, which is the genetics lab with whom we work. It's a process. There are some places all over the world that are validating it. It's a new technique. We have to prove that we can have a good correlation between the results of the trophoectoderm and the free DNA in the culture medium. Okay, so that's once we prove that, and we need a certain number of cycles to prove that, we can start doing it. Okay. The question from NK, yes, it is now available. We can do it at our clinic. We expect to be doing it in about a month, and so, but there are already clinics in Europe, including Spain, where that is already available. But not only Spain, other countries as well. Okay, I don't have the list of places, but there is definitely a lot of countries where that is already available.
Brilliant. Thank you so much for that follow-up. And one more. Would PGTA show any male factor issues in donor IVF? If we have already done FISH, DNA fragmentation, meiosis, all normal.
I mean, with PGT-A, we cannot know whether the problem comes from the male or the female, but we can tell if the problem is there or not. Okay, so if so, we will never know what was the cause, if there is any cause, but we can say whether that chromosomal constitution is normal or not. If the question is if a man with that has done FISH DNA fragmentation and other tests can have genetically abnormal embryos, of course. That's the problem with male fertility. We have millions of spermatozoa, and we are only testing a few ones in all of these tests. So it's, we can have percentages, probabilities, and so on, but at the end of the day, what really counts is what was the sperm that entered the egg. Okay, and that wasn't tested, because if we were to test it, we would have to destroy it, and so we couldn't use it. So the problem is that these issues usually don't affect 100% of the spermatozoa, and so that's where the problem is.
Understood, of course. Again, thanks so much for this. And there will be like 2 parts right now. Okay. I'm sorry, we have a follow-up again, so let me just go to this one and we will go back, of course. You mentioned having a miscarriage with DNC could trigger an immune response. I was diagnosed with hypothyroid after my miscarriage, treated for 6 months than normal. Could this be ongoing reason that impacts the following 8 failed donor egg IVF transfers? What test treatment may be an option if this is the case?
Well, it's DNC, it's dilation and curettage. Okay, that's what we do to eliminate an abortion, miscarriage. So sometimes it's the thyroid problems that cause the miscarriages and not the other way around. Okay, so it's more likely that a thyroid imbalance can cause a miscarriage than the other way around. But at the same time, immune diseases can cause miscarriages, and we know for a fact that people that are carriers of immune diseases, many often have more than one immune disease, and that and those diseases can increase the risk of miscarriage. So, on the other hand, the more invasive we are in manipulation, in exposing the uterus to other genes, to other cells, like in egg donation cycles and so on, we know that can trigger immune factors that can ultimately cause some other problems. So everything is true. Okay, so yes, doing multiple treatments can trigger immune responses that can lead to miscarriages. Yes, doing intrauterine procedures can trigger immune responses that can lead to miscarriage. Yes, having immune hyperactivity can cause miscarriages that need to be treated like this. It's kind of a vicious cycle where that is difficult to abandon. Okay, what is the treatment? I mean, there are many protocols. I believe NK cells will NKs, not cells, NK doctors can certainly help her in the process, but typically we treat it with steroids, with heparin, with aspirin in different regimes and protocols, and that's what medicine has to offer. There is really nothing else we can do.
Thank you for yet another question, of course. And there are like two parts of this question, next question. And of course, thank you for NK for you.
Okay.
Let's have a look, okay? It's Fran, actually, okay? Fran and Ellie. If there is a good outcome with multiple embryos, would the clinic's usual graded quality be the best approach to selecting which embryos to transfer? And I will show you the next. The clinic has advised 2 embryo transfer to give a better chance of a pregnancy with or without PGTA. Is that a sensible thing to do? Does a double embryo transfer really improve pregnancy chances?
Well, maybe starting from the beginning. I would prefer to do PGTA instead of trusting the morphology grading, as I've explained before. Morphology is becoming something of the past. It's still the most easy to use tool. At least we can try to use video time lapse like the Embryoscope, the KidScore system, or other morphokinetic classification systems, not only morphology. Okay, so if the only thing we have is morphology, then we have to use morphology. But if we can use other methods that are more informative and accurate, I would prefer to do it. The second part, can you move forward, please? Okay. So transferring 2 embryos at a time. At our clinics, we always advise one, regardless of the age of the patient, regardless of everything. We always say it's preferable to transfer one because of the risk of multiple pregnancy. Also, so we wouldn't agree with transferring 2. Sometimes when we have patients that have done a lot of treatments always with negative results, or if the embryos are not that good, we might consider advising them to transfer 2. The probability of implantation in principle is an individual probability. So each embryo has its own individual probability of implanting. So in that sense, transferring 2 increases the chances of having a pregnancy on that particular embryo transfer. On the other hand, there are cases, rare situations, especially KIR HLA-C incompatibility cases, where transferring more than one embryo can trigger immune responses that can actually be deleterious, that can harm the chances of a pregnancy. Those are extremely rare situations. Okay, so for the vast majority of cases, transferring 2 embryos increases the chance of having a pregnancy in that embryo transfer. But obviously, after transferring all the embryos in multiple embryo transfer, the number of implanted embryos should be the same, and the risks are definitely lower. Okay, so our advice would be to transfer just one, and if possible to test it with PGTA. And good luck, Fran.
Thank you so much for sharing again, Fran and Ellie. Of course, thank you. And I do believe it was helpful for you. And now might be our final question. Thank you, of course, as you can see from Fran. And this is the question. 38-year-old partner 30 with high DNA fragmentation caused by varicocele, which has been solved with embolization 6 months ago, 4 failed transfers and going through 5th cycle now. Should we do PGTA? We average 2 good embryos per cycle.
I mean, the situation is the answer is yes, because we have 4 failed embryo transfer. So this is a lot. Okay, obviously we have two factors: the age of May, because she's 38, like we've seen during my presentation. At this age, roughly 60% of the embryo of the eggs have an abnormal constitution. Okay, so having made 4 embryo transfers, probably, statistically speaking, we should have one viable embryo. But with just a little bit of bad luck, we might not have any, because these are very low numbers. So PGTA would definitely give May a better notion on whether her embryos are viable or not. Averaging 2 good embryos per cycle, probably that will make the decision easier. The role of DNA fragmentation and varicocele, it's hard to tell, okay, but in principle, this should solve the problem, or at least improve the situation significantly. But we can never know. Normally, the issues caused by DNA fragmentation are not detected in the PGTA tests. Okay, so having a high DNA fragmentation index is not an indication to the PGTA. But so the reason why I say May should do PGTA is because she had 4 failed embryo transfers, not because of the DNA fragmentation test from her partner.
Thank you for yet another advice, of course, and answer to this question. Hope that was helpful, May, as well. And then one more, okay? Let's have a look. Would KIR HLA matching be recommended if doing a new donor IVF cycle after failed 8 previous transfers?
Well, normally having 8 failed previous transfers leaves us on the desperation on the desperation level. Okay, so wherever tests we might do, I mean, we can try to do it. Okay, not we, their clinic, because it's kind of I don't think it's very likely, okay, but still that can happen, because NK tried with 3 different donors. She would have to be extremely unlucky to have all 3 donors incompatible with her, and being KIR AA with donors, her husband being C2, and the donors, all of them having the C2 gene. We all know that after an initial situation where that hyperimmune response is triggered, it could be difficult to lose that adverse environment inside the uterus. But again, so at this point, having 8 embryo transfers, I think it's worth taking a look at it, but not losing too much time, because she's already 50, and so you shouldn't waste a lot of time with things that are not very likely to give any result. You can also decide just to use a prophylactic protocol to treat you as if you were a carrier of an HLA incompatibility, and so that would also be an option. Okay, so this is something for you to discuss with your doctors. We really can't help without having more details.
Of course, that's understandable, and thank you a lot for your questions. As always, you've put lots of details, and thank you so much for sharing. And I hope that it was helpful. I mean, Dr. Silva, you are always brilliant with explaining in detail, so thanks a lot for that. And of course, there are thanks from everyone here for you.
Thank you, guys.
Thank you indeed. And it's always a pleasure to have you. As you know, Dr. Silva, thanks for explaining. And of course, we will be finishing for tonight, but I know there will be some more events with you coming up. So I'm already looking forward to it, as always. So thanks a lot for joining us tonight. I know that it's been a bit of a last minute thing, but I'm glad that you were able to be here. Okay. Anything else you would like to add?
No, well, just to thank you once again for allowing me to participate. It's always a pleasure. I wish good luck to everyone that was attending this webinar. Thank you also for listening to us. And once again, I hope you will always be successful in your treatments everywhere in the world. And so I'm very happy for being here. And if I could have helped a little bit, so I've already earned my day. Okay, so
Thank
thank you
you.
again.
Thank you so much. And you are so kind. Thank you so much here. Definitely. It's amazing to have you. And I'm sure it's been very useful. Everyone have a lovely evening. And of course, we will be back next week on Tuesday. We have another webinar. So I hope you will be able to join us. It's also about PGTA, but this time we will talk about egg donation. So also it might be interesting for you to have a look at it from different different perspective, I think as well. So so thank you so much indeed. As you know, it has been recorded. It will be available tomorrow. Also on our YouTube channel, you can check all the previous webinars with Dr. Silva as well. There are, I don't know how many, but I'm sure it's gonna be useful for you. So best of luck. Thank you and enjoy your evening.
Thank you.
Take care.
Bye bye. Bye bye.
Bye.
Bye.